Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator. It's my pleasure to serve as the host of the CGNE Seminar Series. I'd also like to thank Jenny Rank, our Education Program Specialist, for all of her assistance with implementing our seminars, and Amy Caputo for developing our marketing for this series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at Penn State Ross and Carol Neese College of Nursing in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, entitled Aging Inequalities Among Black Older Adults, Research, Practice, and Policy Recommendations, will be presented by Dr. Kelly White Whilby, Associate Professor of Health Policy and Management at the University of Maryland. Before we begin the presentation, we do have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. To make you aware, this seminar is being recorded. And after the presentation, if you have any comments you'd like to share or questions for our speaker, you can enter those into the chat, or you can raise your hand and Jenny will unmute you so you can speak aloud. New today, due to Jenny's magic with Zoom, we are going to be sharing the evaluation tool with you at the end, at the conclusion of the program. It will pop up in your browser at the end when the seminar ends. It will also be mailed to you via email within 24 hours. If you are an RN seeking contact hours, we require that you complete the evaluation tool, but we also hope that all participants complete it for our data collection, as well as other information that helps us plan future seminars. To earn contact hours, Zoom in and out time is also recorded. And again, the evaluation needs to be completed within a week. The certificates will be emailed to RNs meeting all the requirements within a month of the seminar. If you have any questions or concerns, you can always reach out to us at cgne@psu.edu. Next, I'd like to introduce Amy Cristatello, one of our graduate student affiliates, who is currently enrolled and told us she has 115 days left in her DNP program. Kudos to you. I know she's completed her quality improvement project on undergraduate nursing student wellness. So we're excited to learn more about what you write and present and disseminate about that project. Amy is very engaged with our center, and we appreciate her being here today to introduce our speaker.
Thank you, Janice. I'd like to introduce Dr. Kelly White Whilby. As you said, is an associate professor of health policy and management. She's a program director of health equity concentration and assistant director of the Maryland Center for Health Equity at the University of Maryland School of Public Health. As a social epidemiologist, her work aims to elucidate and subsequently address mechanisms that produce patterns of racial ethnic health inequalities over the life course. Towards this end, she has crafted a research agenda that includes the following 3 foci. 1, examining racism and population health. 2, evaluating the development and implementation of racial equity and social justice policies. 3, identifying structural risk and resilience factors shaping aging-related outcomes and inequities. Her research has been published in leading public health and medical journals and has been supported by the National Institutes of Health and the Alzheimer's Association. Additionally, Dr. White-Wilby has mentioned numerous undergraduate, master's, and doctoral level students and junior faculty. She's committed to using her empirical research to partner with communities and stakeholders to design, implement, and evaluate policies that advance health equity across the life course. I'll turn it over to Dr. Wilby.
Thank you, Amy. Share my screen. Folks, I'm having trouble. I've tested it. Hold on one moment, please bear with me. All right, so thank you for the opportunity to be able to present at your seminar series. Today's presentation will briefly talk about some of the population demographics of the Black adults, discuss some of the mental health care needs along the mental health care continuum, and talk about one of my research projects that focuses on the role of racism and how it influences mental health. And then I'll end briefly with some research, practice, and policy recommendations to further understand and advance equity among older Black adults. So similar to other racial ethnic groups, Black older adults are living older. The overall size of Black older adults is projected to increase with a projected growth of about 12 million by 2060.
Dr. White, if I can interrupt you for a moment, the audio seems softer than what it was before. If you could project a little bit more, and I know we tested it earlier, it was fine, but I'm having a little trouble hearing.
Okay, I will try to do that. Is that a little better?
It is, thank you.
Okay. Black older adults are concentrated in states such as New York, Maryland, North Carolina, Georgia, Texas, California, and Illinois. In terms of a socio-demographic snapshot, approximately 38% have never been married, 22% have a bachelor's degree or higher, 18% live below the poverty line. And when we think about life expectancy, Black women, Black older men have a life expectancy of 78 years, while Black men have a life expectancy of 71.3 years. The life expectancy for both Black men, women, and men is lower than their white counterparts. And then thinking about some of the physical, a snapshot of the physical and mental health profile of Black older adults, approximately 40%, well, roughly 40% have one or more disabilities. Older Black adults experience significant health inequities related to hypertension and stroke, heart disease, cancer, and diabetes, which are among the leading causes of death. These conditions impose significant personal, social, and financial costs for individuals, families, and communities, which can impact mental health. We know that mental health plays a critical role in well-being, independence, and physical health among older adults. Interestingly, several large population-based studies have documented a phenomenon called the racial health paradox in mental health, where older Blacks have similar or better mental health status. For example, anxiety and depression relative to whites and some other psychiatric disorders. This is observed despite the constellation of risk factors, such as lower socioeconomic status, greater rates of physical morbidity and multimorbidity, and disproportionate cumulative exposure to psychosocial stressors that would otherwise predict higher levels of mental health burden. Despite this Black-white mental health racial paradox, evidence suggests that the mental health needs of older Blacks are not adequately met, and are more likely to be underestimated, underdiagnosed, and undertreated in comparison to their white counterparts. Specifically, disparities become more visible when considering unmet mental health care and engagement with the healthcare system across the care continuum. If we think about the continuum of mental health care that represents the range of care points to mitigate risk, beginning with prevention, early intervention, management, and treatment, there are a number of challenges that older Black adults may encounter. For example, older Black adults, research has shown that older Black adults are less likely to seek and initiate mental health services, have mental and behavioral health care insurance coverage, which is a broader issue in terms of mental health care in general, receive care while having access to quality mental health care providers. There's been research that has shown geographic differences in proximity to mental health care providers. Receiving culturally competent care and services, obtaining guideline consistent care, being offered evidence-based psychotherapy, using prescription medications, affording mental health care, and receiving regular outpatient care after discharge. So although we are observing this paradox, that's just at the first point of the continuum of care. And there's still disparities observed throughout the range of the continuum of care. There are several factors that are associated with some of these unmet healthcare needs. They include socioeconomic status, stigma, mistrust, social isolation, resilience related to coping and cultural values. So when we think about stigma, there is a lot of stigma surrounding seeking and utilizing mental health service, which is considered a major risk factor in poor mental health among Black populations in general. Mistrust, thinking about the history, sensitive mental health care represents one way in which the mental health systems can reduce older people of color, the cultural mistrust of mental health. But also thinking about the history of healthcare in this country, a lot of people think about Tuskegee, but there are other examples of Black populations as well as other populations, Latinx populations and Indigenous populations in this country that have had examples of mistrust with healthcare providers. In terms of socioeconomic status, we can think of these factors at the individual as well as at the neighborhood level. And then social isolation. We can think about, and I think last year was the Surgeon General that talked about social isolation as a huge kind of factor for older adults. related to, thinking about loneliness and hopelessness. One kind of area that I am developing research related to resilience. Resilience can be defined as the ability to successfully adapt and overcome negative life events. And so studies have identified several psychosocial factors that may confer mental health resilience and buffer the effects of stress, including family support networks, friendship networks, peer and support groups, peer and social support groups, religion, spirituality, and positive group identity. Also, there are positive coping strategies, such as efforts to mobilize the thoughts and behaviors to manage internal and external stressful situations, which can also contribute to mental health resilience. One of the factors that I am really interested in and I've spent most of my career studying is racism. Kamara Phyllis-Jones is one of my heroes in the field, and I once heard her give a presentation, and she mentioned that, and this is something that really resonated with me, that racism saps the strength of the whole society through the waste of human resources. And so this quote is something that also kind of has been kind of a guiding point or north star in my own research and the ways in which I hope to kind of contribute to furthering health. So racism can be defined as an organized system or set of institutional conditions that structures opportunity and assigns value based on social interpretation of how one looks. And it's characterized by a set of beliefs that subordinate group is biologically or culturally inferior to a dominant group. And Kamara Phyllis-Jones's work has been really seminal in social epidemiologic literature and public health literature in general. That her paper on the levels of racism, which was published in 2000, offered an allegory of the different types of racism. And so she talked about internalized racism, personally mediated, individual level racism, and institutional level racism. And the allegory that she created and weaved into a story was related to how the type of soil that is used to plant red flowers and pink flowers. And so if you have not read this paper, I really highly suggest that you will take a look at it. But it's really provides a vision, kind of understanding the differences between institutional and structural racism, individual level racism, and internalized racism. When thinking about the mechanisms by which racism influences health, it includes psychological and physiological stress responses and health behaviors. And so the pathways by which racism influences health are complex and multi-dimensional, including reduced access to employment, housing, and education, adverse cognitive and emotional processes. One of the most commonly explored pathways is stress, the stress process, thinking about allostatic load, and concomitant pathophysiological processes with really pathophysiological reactivity, such as cortisol and blood pressure and heart rate responses. And many of these patterns of reactivity have been linked to the development of stress-related disorders, such as hypertension and other cardiovascular disease outcomes. Diminished participation in health behaviors, and or increased engagement in unhealthy behaviors, as well as physical injury as a result of racially motivated violence. So I would be remiss if I did not recognize and appreciate and acknowledge and respect the legacy of Dr. James S. Jackson, whose work has deeply influenced my own scholarship and research orientation. And so Dr. Jackson was a longtime director of the program for research on Black Americans at the University of Michigan, and he was one of the leading principal investigators who won the National Survey of American Life. And so throughout his career, he really kind of emphasized and underscored the idea of research on Blacks, and not necessarily in the context of a racial comparison with whites. And so this has been really important in my own orientation when you think about kind of a counterfactual for studying racial and ethnic disparities or inequities, and whether or not comparing whites to Blacks is actually kind of the standard that we should have. And so because of his work, some of my own work has focused just solely on understanding outcomes among Black adults. And I use the term Black as acknowledging that Black people are not a monolith, and the heterogeneity of Black people across the African diaspora that are represented here in the United States. And I think that's also one of the reasons why it is important to be able to study Blacks as a population, because of this cultural, social, historical kind of heterogeneity that influences variability in health outcomes. There was a quote in a recent article by Dawn, I think Dawn was on, and she referenced an article that was published in Science about Dr. James Jackson. So she said he challenged the implicit and sometimes explicit bias that Euro-American norms were the standard against which Black people should be measured and compared, and strive to create a more self-determined body of research on African-American people independent of their white counterparts. So, as I mentioned, his work has been directly influential in my own kind of scholarship and research orientation. So I have a relatively recent project examined perceived discrimination trajectories and depressive symptoms among middle-aged and older adults. So with the projected increases in size, the life expectancy, the socio-demographic characteristics, the physical and mental health profile, and heterogeneity of older Black adults really necessitates investigating exposures to discrimination as a critical step in addressing the mental health needs of middle-aged and older Black adults. So one of the reasons why I decided to focus on racial discrimination trajectories is because one, racial discrimination is a chronic psychosocial stressor that may accelerate biological aging. And a lot of the prior research examining exposure to racial discrimination in health in general utilizes only a one-time cross-sectional measure to predict outcomes at a second time point. And so I was really curious about, based on some life course theory and cumulative inequality theory, are we underestimating the true impact of racism? Are we missing some type of heterogeneity? Are we masking heterogeneity in a dynamic nature and patterns of discrimination over time. And so these single cross-sectional measures can mask significant heterogeneity in a dynamic nature of repeated exposure to racial discrimination. And so being able to identify whether distinct profiles of longitudinal patterns of racial discrimination can add to precision in predicting heterogeneity and health risk is something that was really fascinating, interesting for me and for our research. So we were guided by, our study uses a longitudinal approach, which really draws from life force literature, cumulative inequality literature, stress accumulation, and intersectionality theories to really try to deepen our understanding of the accumulated experiences of discrimination over time and its impact on health. So this study specifically focused on mental health and depressive symptoms, and I'll talk more about some of the variables that were measured. But we really see this as something that can influence other outcomes. And that's something that's been the focus of my research team. And so thinking about these perceived discrimination trajectories, we were really curious to see whether the trajectories would result in distinct exposure profiles. Until recently, research on perceived discrimination trajectories in mental health were really concentrated mainly among adolescents and emerging adults, with very limited studies among middle-aged and older adults. In general, the studies among adolescents and emerging and early and younger adults have shown that membership in perceived discrimination trajectories were associated with unique health profiles, and those with more kind of adverse discrimination trajectories, which may include increasing experiences or more frequent experiences over time, were associated with poor health outcomes. Because of the dearth of studies that have constructed a cumulative measure of discrimination among middle-aged and older adults, we wanted to be able to explore that a little further and see if discrimination trajectories were predictive of health risk. So in this study, to address this gap in the dearth of studies, we sought to create discrimination trajectories, as well as determine whether or not these trajectories were associated with poor mental health status. So in this study, we used the Health and Retirement Study, HRS, from years 2006 to 2018. HRS is a longitudinal study, a longitudinal survey of nationally representative sample of non-institutionalized US adults that are older than 50 years and older. The HRS uses a multi-state area probability sampling, and Blacks are oversampled. And so participants are interviewed biennially in several domains, including health, psychosocial factors, healthcare, expenditures, and service utilization. The original response rate was 81.4%, and rates for subsequent waves have ranged between 85 and 90%. Measures of perceived discrimination resilience are collected from the psychosocial and lifestyle questionnaire, which began in 2006 and is completed by participants every 4 years, with 2 subsamples sampled during alternating years. So this schematic on this slide just tries to highlight the kind of sequence of collecting data on racial, on discrimination. And so, unfortunately, discrimination is not collected at every wave in HRS. But it is one of the few longitudinal surveys that has collected consistently measures of discrimination over time. So this analysis was limited to Black or African Americans, and now we had a sample size approximately a little over 29. Discrimination was measured using the Everyday Discrimination Scale. The EDS is one of the most widely used measures in public health on research on discrimination. It was designed to capture chronic forms of unfair treatment across several domains, and it has shown high internal consistency and validity. So participants are asked how often they experience treatment with less courtesy or respect of others, whether or not they receive poor service than other people at restaurants or stores. People act as if they think you are not smart. People act as if they are afraid of you and you are threatened or harassed, or if one has been threatened or harassed. So responses are typically scored on a 6-point scale. 1 equals almost every day, 6 equals never. In this study, items were reverse coded, and a continuous EDS score was created by summing the scores. If respondents reported discrimination, a follow-up question about attribution was asked. For example, related to ancestry or national origin, gender, race, age, religion, and weight, physical disability, sexual orientation, financial status. And there was an option for other. And so attribution responses were used to create a general discrimination variable and subsequent general discrimination trajectory, which included any category, including race, and a racial discrimination variable and subsequent trajectory. So with the racial discrimination variable, it only included responses that attributed to race, ancestry, or national origin to create the discrimination score. In terms of our outcome, the descriptive symptoms were assessed using the 8-item Center for Epidemiologic Studies depression scale. Items asked if the following symptoms were experienced in the following week. For example, feeling depressed, felt that everything that one did was an effort, sleep was restless, could not get going, felt lonely, felt sad. So positive items were reverse coded, and higher scores reflected more depressive symptoms. We included several covariates that in the models that would have been very important or could confound the association between our discrimination trajectories and mental health. So we looked at several sociodemographic characteristics such as age, gender, foreign-born status, educational attainment, household wealth, labor force participation, marital status, and health insurance status. And we also included clinical characteristic multimorbidity. And so we had a number of eight chronic conditions that were self-reported related to blood pressure, cancer, lung disease, heart disease, and stroke, arthritis, and diabetes. So to generate and to create the discrimination trajectories, we used a repeated measures latent profile analysis. to examine the longitudinal patterns of general and racial discrimination. And so unlike traditional longitudinal modeling procedures such as growth curve analysis, which is a variable-centered procedure, latent profile analysis is considered more of a person-centered procedure. And so the methods differ in the types of questions they answer. For example, person-centered approaches identify patterns of change over time among groups of people that share similar attributes on a set of variables, whereas variable-centered approaches describe associations between sets of variables. In our case, we used the repeated measures latent profile analysis because we had longitudinal data and wanted to identify subpopulations or trajectories of people who shared similar discrimination experiences over a period of time. And so we created two different types of discrimination trajectories. One, a general discrimination trajectory, where there were three groups that were identified. And so for the perceived discrimination trajectory group, identified one group which was low, which was characterized by consistently low levels of reported general discrimination. A second trajectory group which reflected moderate levels of general discrimination, and a third group which we call persistently high, which consisted of the highest levels of perceived general discrimination over time. For the racial discrimination trajectory, we only identified two trajectories. That was, we considered the first trajectory, or trajectory one, low to moderate experiences of discrimination over time. And the second trajectory has persistently high over time. In terms of our analytic strategy, we use generalized linear models with a negative binomial distribution to estimate the association between the perceived discrimination trajectories and depressive symptoms. We built our models sequentially, so our minimally adjusted model only accounted for age and gender, and then the fully adjusted model included all of the covariates. This table just provides kind of a snapshot of the population. And so you can see the distribution of people in the general discrimination trajectories, as well as in the racial discrimination trajectory groups. And so we had a higher number of people in the general discrimination trajectory group in comparison to the racial discrimination trajectory, because due to the number of, there were differences in the responses of people over time. And so to create the trajectories, one of the minimal kind of criteria we had is to have at least 3 measures of discrimination over the time period. And so here we could see that for the general discrimination trajectory, I don't know if you can see my cursor, but most people fell in the low general discrimination trajectory, as well as in the racial discrimination trajectory, most people fell in the low to moderate group. We saw some gender in terms of age. For general discrimination, we did not see kind of huge age differences in terms of those who were represented in the persistently high group. Although for the racial discrimination category trajectory groups, we did see that people who were older than 65 were more likely to, or had a higher probability of being in the persistently high group. We also saw some gender differences in terms of who was more represented in the persistently high. This table shows the association between perceived discrimination trajectories and depressive symptoms among Black middle-aged and older adults. And so we do see that that there is a difference in terms of the association between being in a persistently high discrimination, general discrimination trajectory group, or even and even racial discrimination trajectory group, was associated with different risk in terms of depressive symptomology. And so for the general discrimination trajectories, we do see in the fully adjusted models, somewhat of a kind of a dose response relationship where we see that those individuals, well, the group that has more cumulative and more adverse experiences, and that is more chronic experiences of discrimination, were more likely to report depressive symptoms. In terms of racial discrimination, we only had two groups, so we weren't able to kind of have that nuance, but we do still see that those who were in a persistently high group had a higher, were more likely to experience depressive symptoms or elevated depressive symptoms. We looked at gender and age stratified analyses for both the general and racial discrimination trajectories, which are presented here. And so in adjusted analyses, the most pronounced risk for elevated depressive symptoms was observed among respondents aged 65 and older in the persistently high discrimination trajectory. An elevated risk of depressive symptoms was also observed among individuals age 65 and older in the moderate general discrimination trajectory. Among individuals aged 50 to 64, the risk of elevated depressive symptoms was highest among those in the persistently high trajectory. And so we see a gradient was observed among men in the persistently high general discrimination in the moderate general discrimination trajectory class. Women in the persistently high general discrimination trajectory class had a higher risk of elevated depressive symptoms in comparison to women in the lowest general discrimination trajectory. We did not observe any interactions between general discrimination trajectories and gender, between racial discrimination trajectories, age, and gender. So in terms of thinking about what these analyses mean and kind of some of the next steps. So one, in terms of limitations, as I mentioned and showed you, that these measures of discrimination are only captured every 4 years. And so there is kind of, they're not, ideally, we would want to measure discrimination more frequently, but this is the best kind of information that we have. And we do still see some influence in terms of stratification of kind of risk related to experiences of discrimination over time. Another kind of limitation of the study is kind of thinking about the measurement of discrimination. And so it only captures one element of discrimination, and it's discrimination at an individual level. And so the everyday discrimination scale does not take into account or does not measure structural discrimination or racism, which can also impact mental health outcomes. over time. One of the strengths of this study is that we see this research kind of adds to the necessity to study heterogeneity within Black populations. And so we think this would help with being able to create and develop maybe more race-based trauma interventions to help with the mental health needs. There are several different ways in which we are planning to expand and build upon the results of this study. One of which was supported by a Research Centers for Collaborative Network, which is a National Institute of Aging center study. And so in that study, we were looking at how associations between general and racial discrimination trajectories are associated with multi-morbidity burden, using the same kind of health and retirement study. This study additionally kind of identifies resilience factors that are associated with discrimination trajectories. And so that's what we kind of, what was limited by the study I just presented. We were not able, or it wasn't a focus, and we did not look at kind of what is the breakdown of these trajectory classes? What makes them unique? What makes the classes different? And so in this pilot project, we're looking at social and psychological resilience to see what's, to further understand the profiles of people in each of the trajectory groups. And we're looking to see if this is related to multi-morbidity burden, which we believe is kind of a proxy for biological aging. We also have started some analyses where we're looking at the perceived discrimination or the discrimination trajectories, both general and racial discrimination trajectories in relation to cognitive functioning and Alzheimer's disease risk. Just in general, in terms of thinking about opportunities to advance mental health equity, we can think of this in kind of 3 prongs related to research, practice, and policy. And so having more studies, and I know that this may seem trite to some, but more studies that are focused on Black older adults. There was a recent study by Roberts that found that a large proportion of the psychological research was focused on samples that were predominantly white. And additionally, the journal Clinical Gerontologists conducted a diversity review of published manuscripts and also found similar findings, which led to the initiation of a special issue on Black older adult mental health. And so having more studies to be able to really kind of understand the nuances and the complexity of the outcomes that we observed. I think critical reflexivity is also very important to advancing kind of mental health and health equity research in general. And so being mindful of the ways in which biases, whether they are implicit or explicit, can impact the formulation of hypotheses or study design, data collection, interpretation. Having diverse and inclusive research teams, and that may play a role in, not just in terms of kind of race ethnicity, not just specific to race ethnicity, but having diverse and inclusive research teams may help with the recruitment of participants and interpretation of results. but also thinking about kind of the diversity of academic expertise, especially like having sociologists or anthropologists involved in studies. Recruitment of participants is definitely a challenge and a lot of research disciplines. Thinking about intersectionality, which adds a really interesting layer for being able to target programs and interventions. And then also resilience, which is something that is really interesting to me. Ever since I've started my career as a social epidemiologist, there was always talking about health disparities was always from a negative perspective. And so being able to understand how certain groups of people are able to kind of still do well in spite of. And so even though resilience, I think there's more of an effort to understand resilience factors, that comes with caveats too, related to overemphasizing the role of resilience, particularly as it relates to Black older adult mental health, because some studies have found that resilience, like the superwoman, slipping my mind about the full name of the coping strategy, but also John Henryism and how that can exacerbate mental health illness. When thinking about policies to further advance, to further mental health equity, we can think of policies related to little p policies, which are those within department agencies that includes organizational practices and protocols and funding norms, as well as big P policies that include legislative action and or a city ordinance. And so this list covers both kind of big P and little P's. And so being able to improve the affordability of behavioral health insurance coverage and care, expanding access to behavioral health care services, increased resources and funding for mental health care services, and even expanding and standardizing payment models for community health workers could be a really huge kind of game changer to ensuring that that there is greater access to services. And then also kind of remove more structural barriers, in oppression. And then kind of lastly, kind of thinking about practice, which is probably something big and on your minds as nurses and nurse practitioners, but thinking about the integration of mental health services with primary care can help to provide more collaborative patient and whole person centered care. And so integrating behavioral care into primary care addresses fragmentation and a lack of coordination in thinking about culturally competent and tailored provision of care, and training of a diverse mental health workforce, and being able to enhance the availability and capability of telehealth, and utilizing community health workers. I think I'm probably over time, but one of my intellectual heroes is W.E.B. Du Bois. So, in one of his seminal studies, which I have written about, is probably a harbinger of social epidemiologic research, the Philadelphia Negro Study. There was a quote that really kind of resonated with me. Nevertheless, here are social problems before us, demanding careful study, questions awaiting answers. We must study, we must investigate, we must attempt to solve. And so hopefully, some of the information, I know this is just really a snippet of kind of, some of the work that I am doing, but some of the work in the field about older Black adults, but hopefully you all come away with something to kind of move your own research further, to maybe collaborate with others in terms of advancing equity among older Black adults. And that is all I have. Thank you.
Well, that was way more than a snippet. That was outstanding, Dr. White. What a very interesting and informative presentation. And I love the way you provided, us with the foundation of some of the, background related to risks and decreased access for older Black adults, as well as the mental health paradox. And then, the theoretical framework and methods you used to implement this amazing research with really important findings, and love what you're already doing to extend this work because it's so incredibly important. And in terms of getting at not only the general and racial discrimination and how that impacts health status, especially related to mental health and risk of depression. But I love how you're kind of shifting to identifying resilience factors and trying to, promote wellness in a way that hopefully will be helpful to older adult Black Americans as well. So thank you for this outstanding presentation. Unfortunately, we don't have time for questions and comments, but you had such a wealth of information. I wanted you to just continue sharing, so I didn't want to interrupt. But thank you to everyone that participated today. Please know that when Jenny ends the Zoom link, the evaluation tool will pop up in your browser. You can complete the evaluation right away, or you can save it for later, or you can do it within the next week, because you will receive an email within the next 24 hours with the link to the evaluation. So lots of options for completing the evaluation. We'd love to have your feedback. Again, Dr. White-Whilby, thank you so much for joining us today, for sharing. And I hope that this is just the beginning of us continuing to learn from you.